alleviate. Tonight's speaker is Dr. Samuel Hamner. He earned a bachelor's in mechanical engineering at the University of Florida. He then moved to Stanford for a Ph.D. in mechanical engineering, where he studied human movement in the neuromuscular biomechanics lab under Professor Kelp. And currently he is a design engineer at D-Rev. So go ahead and join me in welcoming Dr. Hamner.
Thanks for having me. I just heard that apparently Madeleine Albright is talking across the way, so thanks for coming. Stiff competition that I have to give a talk sometimes. I'm kind of going to give an overview of what D-Rev does, and kind of our work and how we think about it, and then I'll talk about the two products that we work on. But feel free, I'm hoping this can kind of be interactive and open, so feel free to stop me and ask questions as we go along. I kind of like talking to you guys instead of just talking at you the whole time. So, I guess I'll give a little bit of background about myself first, though. As Kevin mentioned, I did my Ph.D. in biomechanics at Stanford in the neuromuscular biomechanics lab. And, I worked on software to study human movement, and so this is an example of a simulation I made of human running, and someone made this figure that looks really cool. While I was at Stanford, though, I was fortunate enough to be part of a class called Design for Extreme Affordability, and that's kind of what pushed me into the work I'm doing now at D-Rev. While I was in that class, I was on a team that helped start this product, which we call the Pepper Eater. It was a grinder. It is a grinder to take dried red chilies and break them down into these small flakes, like you see here, which is a very common process that we saw women in southern Ethiopia doing as a source of income, because there's a spice called berberine that's kind of in everything. It's ubiquitous in Ethiopian cuisine. So we really wanted to provide them a tool so that they could, because when we saw them, they were breaking these peppers by hand. Each flake, and it was very tedious and painful. That's kind of one of the big insights, is we actually got peppers in our eyes. So we wanted to give them a tool to help them improve their income and reduce that burden. And after the class ended, we were actually fortunate enough to be able to license the technology to a nonprofit in Minneapolis called Chemical Technology International, who's still working on taking that forward. So that's a little bit of background about myself. So now I'll just dive in a bit about what D-Rev is. So we like to talk about ourselves as being a nonprofit product development company that develops tools to empower people living on less than $4 a day. And we really have focused on two key aspects to help achieve that goal. We focus mainly on products that will either improve someone's health and or their income. We also try to work on products that will have a large impact on society. So we want it to really affect a lot of people. And so what that really means is, at the beginning, when we're looking for needs, we really want to make sure we're identifying a need that is crucial and going to have big impact, and that technology can actually make an impact for those people. And I guess that kind of brings us to what we think of as our process, our design process. So we're a design firm. I think every design firm has to have their own process, and this is what ours looks like. And it's pretty similar to lots of other ones, but we think it's important to think about this whole process from the beginning of product development. So in my past experience when developing technology, it's really been about, you have some key user specifications. So you go off into your lab, you build a product, and you say, okay, I met those user specs, this should be good enough. But the way we like to think of it at D-Rev is that pretty much we want everyone involved in understanding the problem from the beginning and using a user-centric process to kind of do that. So we start on the left hand of this arrow, we say it's at the identify phase. So we really try to keep a broad, open perspective when we're trying to understand what's the next need, what's the next problem we're going to look at. We then focus on, once we have a clear problem, we focus then on designing the solution. And then working with users to make sure that that solution is really addressing the need that we identified in the first phase. Once we feel like we have a working product, the next part of the problem, and that's where a lot of people stop. They have a proof of concept, you have a prototype, but that's kind of where the real work begins, is in delivering the device to the end users in these places where there's not good infrastructure or whatever challenges you're going to have to overcome in the supply chain. And then really, how can we amplify that? How can we scale it? And then the last component, and it's the bottom, smallest piece, is called measure. But I think it's something that really attracted me to work at D-Rev, is making sure that we understand how we want to measure the impact of our device, and that we are doing that as the product is still being rolled out, as the product scales. So how can we design things into our devices that will make it easier for us to make sure that they're effectively treating the people that we want to help, or that we want to treat? So that flew through that. Does anybody have any questions? So we kind of try to have 3 principles that we keep in mind throughout that entire process. The first one is that we really want to make world-class devices. And so a lot of times, when you think about making an affordable product, you might start with, say, okay, well, here's an expensive solution that's achieving what I want to do. Maybe we can just strip away some of the fancy bells and whistles, and then we can get something that's affordable and get there. But a lot of times that leads to kind of products that are inferior and that you wouldn't use yourself. So we really strive to make medical devices that we would say would look normal in maybe Stanford University Hospital or wherever. We want them to be world-class. We also make sure that they meet all of the world standards in the specific field that the product is in. So for example, this is a picture of phototherapy device to treat neonatal jaundice. And I'll go into a little bit more of what that is, but they're standards set by the American Society of Pediatrics, or American Academy of Pediatrics. And so we do diligent testing to make sure that we are meeting or exceeding those standards, so that when we send out these products, the child is most likely going to be getting the most effective treatment that they can. The second principle we try to embody in all of our products is using a market-driven approach. Some people might call this a sustainable approach. But we really want to make sure that when we're figuring out that deliver and scale phase, that we're not just donating products, but that we actually can incorporate the costs of manufacturing and delivering device, distribution, and all those things into the business model, so that the product, if D-Rev goes away, the product can actually sustain itself. Another example I can talk about for that is with our phototherapy device. We've actually licensed the technology to a medical device manufacturer distributor, and they've moved forward with the design, kind of with us working in parallel. But we like to think that if D-Rev folded tomorrow, this product's already on the market, it's making money for the company. So if we didn't exist, that product would still be out there, hopefully treating babies in the future. And then the last part, and I kind of mentioned this already, but it's this idea of being obsessed by the user, and really starting with people and understanding what their needs are and talking to them, and really getting a sense of what is the big need in their life, or what is the big issues that they're dealing with. And that's kind of typified by this picture of one of my colleagues doing a user interview. But it's also about understanding who are all the stakeholders in a value chain associated with your product. So for a medical device, that can get pretty complicated, because a lot of times the person who's using the device might not be the person paying for the device. So it might be someone at the clinic, a procurement officer who's making the decision about which devices to use and supply in that clinic. And then there's a doctor that prescribes the treatment. And then there's a nurse who actually has to do the work, because the medical doctor tends not to want to actually do the work. I guess there's no medical doctors here that I can make fun of. But anyway, so we really try to look at who are all those key stakeholders, how are they connected, how does information flow and money and everything flow between those key stakeholders, so we understand what they're looking for in the product and how we might be able to incentivize them to perform better treatment or whatever we need to do to deliver our device. So, as I mentioned, D-Rev is a nonprofit, but we kind of have this catchphrase or tagline that we try to act like a for-profit. So we use our nonprofit status really in the first half of this of our process here. So we use philanthropic donations and grants to kind of subsidize the R&D and development of a new product. But then once we've kind of developed the concept, we really go back and want to use the private sector to deliver the product, because we think that's the most effective way. Using the market will be the most effective way to distribute medical products globally. And so since we are a nonprofit, we kind of, it goes back to the end of the day of that impact, that measure part of the arrow. And so that's what we really see, that's what drives us personally. We have big numbers in our office that show this is how many people we think our devices are reaching every day. And that's kind of what drives us and is our biggest motivation at the end of the day, is how many people are we actually reaching with our devices. Okay, so that's the brief overview of D-Rev, and so now I can dive into a bit more about our products. So the first one I'll talk about is our remotion knee. And I'll talk about this one first because it's kind of the product that I work on the most, having a background in biomechanics. Prosthetic joints are kind of, I find fascinating to work on. So to give you a bit of background about amputee, the numbers of amputees living in the world, the WHO estimates that there are about 10 million above knee or thigh level amputees living in developing countries. But the sad reality is that only 5% maybe are actually getting a prosthetic device. So there's 9.5 million amputees without a medical device, so they're getting around on kind of whatever they can in terms of making a homemade device, so be it a bamboo staff or a crutch or something like that. So our goal is really, we want to provide a tool for these 9.5 million amputees who aren't having access to care to restore their mobility.
Question.
Yep.
Do you know the rate of change? Like how many per year? How many amputees?
There's about 3 million per year that need a new device, because devices also wear out. But that's what we estimate. And then those numbers, you know, I always feel like the WHO numbers and these big top-down approaches on numbers it's the best estimate we have. But yeah, that's what we come out to about, is about 3 million new devices per year, and that's only for knees, above knee amputees.
And the root cause is?
The main driver is auto accidents and train accidents. A lot of people think, and even myself, that you think about maybe landmines or war as being maybe the top cause, but it's surprising that it's the traffic accidents. Someone was asking me earlier about men versus women that we see in the clinics, and we tend to see more men. We're not sure exactly why that is. We think that maybe one hypothesis is that if train accidents and motor accidents are the driving cause, maybe men tend to have risky behavior or something like that. But we don't know. Maybe there's such a big stigma around women coming into the clinic that we just don't see them as often. That's kind of a big open question, I feel like, for us. So here's an example of 3 typical patients that you might see. These were patients that my colleagues met in India back in 2009. this is kind of what if you don't have access to a device, what you have to do. You either have a wooden staff or a crutch, and it severely reduces your mobility. And there's also a huge social stigma in many places where if you're an amputee, you're really looked down upon or outcast. So it's a big deal when you don't have the mobility that a prosthetic can provide. So in the US, we have state-of-the-art solutions. So this is an example of a micro-controlled hydraulic knee called the C-leg. And this is what maybe a vet coming back would be prescribed. It works amazingly well, but at a price tag of $20,000, it's impossible for us to really deliver this type of product to people living on low incomes. On the other end of the spectrum, there are low-cost devices out there. So this is an example of one. This is a plastic knee made by the International Committee for the Red Cross, or ICRC. And it costs about $150. But one of the big limitations of a device like this is it actually uses a mechanism that's called a single axis mechanism. So when you think about a single axis as having the same motion as a door hinge. So it's got a single pivot point. And it's much more unstable and requires much more effort for a person to use this type of device, especially at heel strike. And so I'll show you a video actually of a patient using a single axis knee. Now this is this isn't the ICRC knee, but it's still a single axis knee. And you can see the person, he's having to take very tentative steps. He's having to use his hip muscles a lot more to really lock out the knee at foot strike. And it's really psychologically and physically draining to walk around that way because you don't know if the next step you're going to take if you're going to fall. You can't really trust your prosthetic. And so the remotion knee was developed using a concept called a polycentric or 4-bar linkage mechanism. And that's actually something that's been around. It was actually somebody else that was actually developed. Most of the research was done here at Berkeley to characterize polycentric prosthetic knees. But it's really a much more stable device. So you can change the point of rotation so that when the person lands, they know it's not going to buckle. You can slightly change the geometry and make their gait much more stable and much more efficient. So I can probably pass some of these around. So I actually got a video here. So this was actually the first patient fit with the remotion knee in Jaipur at our partner clinic, the Jaipur Foot Clinic, or in India. So he had a device before, but it's pretty impressive to see the first time with him walking with this device to have such a natural gait and not really walk in a really conservative way. It looks like he feels very comfortable there. So I guess I'll give you a brief background about the product. So I have three versions here with me, and I'll pass these around so you guys can look at them. So this first version, and the knee that you just saw in the patient there, was actually developed by a student team at Stanford. So the Jaipur Foot Clinic in India, they are one of the biggest fitters of prosthetics in the world. They came to Stanford and they had the single axis knee, but they knew they wanted something that was better. So they came to the student team and said, can you come up with a low-cost, affordable knee that's more stable than the one we have now, that has better performance, without driving up the cost. And so the student team actually, this is the prototype that they came out with, and it integrates into the Jaipur Foot's system, their whole leg system. And the student team actually continued working on the project after they graduated, and eventually ended up merging with D-Rev. But during that time, there was some critical feedback even just then. So this kind of gives you an example of that whole user-centric mantra that we were talking about. Is in 2009, the Jaipur Foot Clinic just started fitting patients. There were more and more knees being put out. So we were able to get feedback very quickly about the design, what people liked about it, what people didn't. And so when the team went back and visited again, they started to see people had their own hacks around some of these issues. The team really thought things like the stability and how, the strength, and they were engineers, and they were thinking those were going to be the aspects that were most important to people. But it turns out the social stigma around being an amputee was kind of the main driver for a lot of the features that users were looking for. So if you notice, this knee, it's kind of got some sharp corners. And it's a bit fat. We have these really wide, side linkages here. And so when a person sat down, it was clear under their pants or skirt or dress that they had a prosthetic knee. They didn't have a natural knee. So this guy went as far as to build his own foam piece to go over the knee, just so that it would look more natural. Another aspect that we learned quickly is that this knee actually has plastic on plastic connections, so the top and the bottom piece come together. But when you swing your leg into full extension, it makes a clicking sound. So when you're walking down the street, you're going click, 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 and I mean it's kind of a giveaway that you have a prosthetic limb. So we saw people fashioning their own noise dampeners and attaching them to the bottom of the knee joint. And so that really drove kind of the next phase of design and led us to what we call version 2. And so that was looking at how we might be able to give it a much more natural looking curvature on the front, so it looked like a natural knee under pants, adding a noise dampening feature so it doesn't click as loud. We also switched, you could see too, if you look at the top of the knee, we switched the connection method. So at the Jaipur Foot Clinic, they have a proprietary system for how they connect their knee joints. And we knew we wanted to scale and be able to reach clinics globally. And so we also switched over to a more standard connection mechanism called a pyramid connector. So this is kind of the standard, in prosthetics world, this is the standard way of attaching a knee joint to a bottom of a socket. So that was another big change in that design. And so we developed this and machined them out of plastic here in California, put them together and did some field trials. But we knew that this was not going to be the long-term viable solution because, again, we were really focused on having that large-scale impact. And so in the last couple of years, we've been working on version 3, and I'll start this. Version 3. And you can see it's thinner, it's a little lighter, but the biggest difference is how it's manufactured. So we've switched from a process called CNC machining. So both of those knees are cut with a milling machine. So each feature has to be cut away out of plastic. And we've moved over now to an injection molded design. So we can create molds. It's kind of like, if you don't know injection molding, it's kind of like Play-Doh. You have a mold, you inject hot plastic, you open the mold, and your part pops out. So we can make lots and lots of parts, and we can control the quality at high volumes, unlike if we had to manage lots and lots of different CNC machines all over the world at different clinics. So we've really been driven to a centralized approach in this last version. And so we're actually in the middle of field trials now. We're working with 4 clinics, 2 in Indonesia, 1 in India, and 1 in Guatemala, to do a 6-month study on this last version before we go into final production at the end of the year. So we're kind of trying to get that last bit of feedback before we really ramp up production. But we hope to be for sale by the end of Q4 this year, and our projected retail price will be $80 US. So yeah, I can go ahead and pass this around too. And so just to bring it back to that impact piece, Through our partner clinics, we've since 2009 have already fit just over 5,000 patients with a need. And we've done our own informal surveys, and in the first 2 years of usage, we got a compliance rate of 79%. And that just means that 79% of the respondents to our survey were still using the device after a 2-year period. So, I mean, and I think that's important to look at other metrics. You know, we don't want to just look at how many knees were sold, but we really want to identify how many knees were sold, how many people are still using them, and in this field survey that we're doing now, it's also how does that affect their life? Does that affect their income? Does that affect, you know, how much they can do in terms of their physical mobility and things like that? So we're really trying to dig into those numbers.
Have you guys gotten a lot of response from sort of what percentage of surveys sent out returned with answers?
With right answers?
Yeah.
Yeah, that's a good question. It's a challenge. So the numbers that came from here was a phone survey. So we had people at our partner clinic call each patient and just do it over the phone. So that's why I said it's very informal. I don't know. You can't put a lot of trust in the numbers. It's just how much that you trust that the patient's giving you that right information. So that's really why we focused this last year on doing these more longitudinal, a bit more high-touch kind of surveys where we're working with the clinics to identify patients who represent a broad kind of spectrum of different people, but also who can come back to the clinic. Because it's a big deal for people to even just come back to the clinic because they have to take off from work. Usually they're coming from 2 or 3 days travel, so they may have to stay in a hotel or something. So we did a lot to try to make sure that we could actually get the patient back in person and measure things ourselves.
Do you have some sort of incentive system in place to get people to come back to the clinic?
Yeah, so we definitely so first of all, we did everything through an IRB or institutional review board protocol. So there are certain rules and things that you can do, but we did offer a stipend to cover like transportation costs and kind of the burden, just kind of ease the burden that a patient would have to come back to the clinic. So, and it depended on the clinic that we worked with. Some clinics had such a good relationship with their patients and they already were going out and visiting them. Those are kind of our favorite clinics because we think that they're kind of on the leading edge of models of prosthetics care because they're going out into the community and talking with people. But then some of the clinics aren't doing that, so you know the reimbursement was kind of a good way to get people back.
So the distribution, I guess the delivery section, which is the profit section.
Yeah.
So does that mean the $80 essentially covers? So how much does that cover? Is it just the price of the product, or also like whatever distribution is associated?
It's delivery to the clinic door.
Okay.
And so in parallel, while we're doing kind of the field studies and stuff like that, is we're doing kind of the business development to build out that supply chain, working with logistics partners who can help us, you know, get through customs, because every country and every market we enter into is different. There's going to be different hurdles in how we get to different customers, but building all that cost into the cost of the product. So yeah, the group's called. I'm learning about 3PLs, and that's kind of third party logistics providers, and that's really kind of what we're looking at in terms of how we can distribute. Because we're doing that centralized model. We'll be making everything in one place and then trying to take it out to lots of different clinics. See another?
I was wondering about the 21% who don't use the device after 2 years. Did they talk about why?
Yeah, it's a range of reasons, and it's hard in that kind of survey to isolate what it was exactly, because when they say they're not using it, it could be for a number of reasons. It could be that the socket wasn't fit well, so maybe they just stopped using it because they were getting a sore on their leg or something like that, or the foot, something could have been wrong with the foot. We actually have numbers on failure rates of the knee, and it's higher. It's only 90. I think only 2% of them failed in that study, or at least that's what we got back from the respondents.
Yeah.
So Mechanical failure, it might be different than this compliance number.
Right.
But yeah, that's definitely something when we do this longer study, it's a bit more in depth, we can hopefully tease out, why did you stop using it? Was it because of the socket fit? Was it because of something in the knee? Was it because of something in the foot? Because this isn't done in a vacuum, and it's really important that we work with clinics and partners that have the skilled prosthetists that it takes to fit a prosthetic, because you have to have someone with, it takes 3 years to kind of be trained properly to do that, and that's a critical aspect for adoption. And also having the right training. So a lot of these clinics, people come in, they get fit, and then they're just sent home, and there's really no gait training or rehabilitation that goes along with it, which is kind of key for long-term success with a prosthetic device.
This might be a dumb question, but is it really a one-size-fits-all device?
It's one size fits most. Right now, it's really the only limit is is either your age, so it really won't work on or the size of your frame. But after about 13, most people have developed into a mature gait, so their kinematics are kind of the same that they're going to be for the rest of their life. So anyone above 13 would be suitable, and then the max weight is 80 kilograms. So that might sound, that's kind of low if you think about the United States. It probably wouldn't cover most of the most amputees, but I think we've done calculation that should cover like 95% of the population in India or something like that. So, but yeah, we're thinking about pediatrics, kids' knee. That might be one of the next things we work on.
I'm curious about the efforts of the design process. How many people involved and how many months? What does it take to get between version 1 to 2 to 3?
Yeah.
And what is the composition of that team?
It's a lot. I mean, you want to think, we draw that arrow and it's this nice linear process, and I mean, there's a lot of things that happen because of opportunity and things like that. But so the project started in 2009. And it was 3 people. And then eventually the team merged with D-Rev, and then they had a whopping 5 people working on it. But the key is, this is an important part too, is that we work with lots of partners. I think D-Rev right now, our count is at 20 partners that we work with, because we know that we can't do everything. And so it's really important too to leverage those relationships. So like, we wouldn't have been able to get this direct customer user feedback without the Jaipur Foot Clinic. That was a huge, I think, in the insights that came out in designing the product and really getting lots of users using the knee. This 5,000 wouldn't have happened without Jaipur Foot. So I don't know if I have that's a great answer to your question.
That is a great answer. How many partners for a project like this then? What kind other than user feedback?
So I mean, we partner with anyone from a group like Exponent, which is a company down in Menlo Park. They have offices in Oakland too. They're just research scientists who can help us do things that we're not able to do ourselves. So mechanical testing, simulations, things like that. I've been working with UCSF. They have an orthopedic. I always forget the acronym, but they have an orthopedic training program for surgeons all over the world. And so we work with them to find the prosthetic schools so that we can go visit with them. And they also have resources that help us do testing and things like that. So, yeah, I don't know.
Yeah, keeping on the line of questioning around the process.
Yeah.
Clearly the user feedback is essential. And I was wondering, sort of how focused the questions you ask the users are versus kind of having a general conversation with them. It seems like if you went in with an expectation of certain mechanical features needing to kind of be the main improvements, but really it's cultural things, you have to be pretty open here.
Yeah, definitely. I think when you start out in the process, I think it has to be way more open. You're not going to know what specific questions to ask. So it's really kind of just, you're trying to learn about the person and about the people. And really let them tell you stories of their life and kind of get as much information as you can, and then go back and start to put the pieces together after you've done the field work. But that's really only in the very front end of the process. At this stage in the game, we kind of have a hybrid approach where we kind of know what targeted questions we want to answer, but we don't want to miss those like rich nuggets of information that aren't going to come out on a 1 to 10 Likert scale, or, you know, are you satisfied with this knee when you walk upstairs? Like, I mean, those are some of the questions that we actually ask on one of our surveys, but then we try to have those still have room for those open-ended questions. Another thing that we really strive at is getting everyone who works with D-Rev out in the field so that they can talk to people, talk to users, and get that kind of firsthand empathy. So I think that's it's a kind of a subtle thing, but I think it's a big part in really understanding as a designer what you're working on and how you can make, when you're making the trade-offs, once you're back in the lab or back in the workshop, you can go back to kind of those experiences.
Another question about the user feedback. Do you stay with the same users testing as you sort of iterate through the designs here with the people who started using the first one?
We would love to stay with the same user, but it's really hard, and this is a bad joke, but once you give someone a knee, they walk away, and they don't come back, and they really don't. It's been really challenging for us to get people to come back and provide feedback, so that's why it's been really important in this study that we're doing this year. That was our main goal, is to identify clinics that had patients that could come back to the clinic, so that we could at least get 2 snapshots in time of the same person, and to see if there is any improvement, if they like it, how does it compare to previous devices that they've had, if they've worn a prosthetic before. Because I think it is important to kind of get that longitudinal information from a single person's experience with the product. So the answer is I wish, but not. We really haven't talked to anyone in more than a year out. Any more questions? I think that I'll move on.
Could you talk a bit more about the funding and kind of, you know, where those grants are coming from, and if you see yourself in the future moving towards more revenue and moving away from the grant funding?
Sure. So a majority of our funding now comes from philanthropic, like grants from family foundations, not grants, but donations and private individual donors. And then we are starting to get more grants like through USAID or other groups. We haven't gotten a Gates grant yet, but I think we're working on that. But yeah, we really do want to diversify our revenue and have the products bring some money back into our revenue stream. And so we do get royalties on the next product I'll talk about, the Brilliance phototherapy device. It's on sale, and we actually are getting royalties on every sale. Okay. I forgot to do this slide. So this just shows you kind of where the knees touch. So as I mentioned, we've worked with the Gyber Foot Organization, and they do fitting camps with the knee all over the world. So mainly in India, but they've touched a lot of other countries as well. Right now, we're working on the field trials in India, Indonesia, and Guatemala. And we constantly get inquiries from people looking for how to get the knee, and so we kind of map that just to give us a sense of where is the interest building, where we might be able to target, what countries we might be able to target first as we roll out the product. And that's a patient in our field trial. Okay, so how many people know what jaundice is? Everybody? Pretty much? Okay, so I actually found out I had jaundice when I was born. So when you're born, a lot of times the liver is not fully developed, so it can't filter out a toxin in the blood called bilirubin. And it gets deposited in your skin, and causes you to look yellow. The condition is actually called hyperbilirubinemia, and jaundice is the expression of having that disease where you're not able to filter out this toxin. And after a while, it can actually build up and cross the blood-brain barrier and get to your brain and cause long-term brain damage or even death. So some numbers around that are that we estimate that about 60% of children have some sort of jaundice. So like in my case, I found out I had mild jaundice, so the doctor just told my mom to put me in the window and use sunlight, and that was enough to treat it. But 12% of all children have severe jaundice that require treatment by phototherapy. And that number is actually, we think that number might be a little low. That's including higher income countries. We think that it could be as high as 17% in lower income regions where there's more likelihood for preterm births and other things that can raise the risk factors for neonatal jaundice. So it's actually, we see it's the #1 reason that babies have to be brought back to the hospital. So they may be discharged, and the mother identifies that either the child's not feeding, or other issues that can come up with jaundice, and they have to bring the child back. Like, the thing that's critical about jaundice is it's super time sensitive. A matter of hours can make a huge difference in the health of the child. And so our goal with this device is really to end the risk of brain damage and death associated with neonatal jaundice. I've actually learned something a couple weeks ago, is that connectress, so that's the name for the disease, the brain damage that a child will get from neonatal jaundice, and that's labeled in the US as a never event. So if a child actually gets bilirubin levels high enough to cause permanent brain damage, connectress, it's immediate malpractice in the US. It should never happen because it's a simple treatment that can be used to eliminate the jaundice. And it's pretty amazing to me as like a scientist or an engineer is that the treatment is just shine a very specific wavelength of blue light onto the child's skin, and that will break up the toxin. And as long as the child is being fed regularly, then they'll be able to excrete it out, and the bilirubin levels will be brought down and will prevent brain damage. And so this kind of gives you a breakdown of what we estimate as the unmet need for phototherapy. So this is how many babies are being born in each of the regions. So we kind of lump Southeast Asia, Africa, and South America are requiring phototherapy or have severe jaundice. So in our fieldwork, we kind of identified a few challenges with existing systems that we saw. So these pictures are mainly from India, our fieldwork in India. The first thing that you see, the first thing I noticed, there's two things wrong with this picture. Maybe you guys can do a little exercise. What do you guys think is wrong with this picture?
Light's not blue.
Light's not blue. So white light does contain blue light in its spectrum, but it's a very small part of it, so you're using a lot of energy is going to be wasted because you're shining white light. And it's actually really funny. We found information published by the WHO. We even found information on Duke's website. There's still misinformation about what's the most effective. So the WHO, we saw a book that said use white light bulbs, which we know is not the most effective treatment. So there's still a lot of misinformation too around jaundice. What's the other thing that's wrong?
Some of the lights are out.
Yeah, some of the lights are out. So a lot of the devices, phototherapy devices, use fluorescent tubes. And fluorescent tubes burn out every 3 to 6 months. So a lot of the times you'll go into a hospital and you'll see a device with burned out bulbs. This is another common thing we see is that there's just a lot of these clinics have such a burden that you're having to put multiple babies together into one unit that was really meant to treat one child. So this is just a kind of a picture showing, this is an underside unit, so instead of having the light shine from the top, it's coming from the bottom. But at least they are using blue light, but it's 2 children. There's really only 1 bulb out of maybe 4 or 5 that are supposed to be in there. Just give you a sense of what we see. But a big challenge, or a big barrier with those fluorescent tubes is that once the hospital buys the device, there's still a large cost in maintaining the use of the device, because as I said, they burn out after about 3 to 6 months. So every time we go to a different country, we try to figure out, well, what is the cost, what is the replacement cost of those bulbs? So in Delhi, it's about $23. Manila, it's $55. Nairobi, it's about the same. Kampala, we saw that they were up to $185, and mainland it's $50. So that's just the cost of 1 bulb. So each unit has can have up to 6 bulbs or more. So if you think about that, the bulb replacement cost per year it just goes up huge. It's huge. So that can be a real burden on a clinic who's kind of has a resource constraint. So that's kind of one of the major drivers that led us into our development of Brilliance, is the moving away from that CFL technology and kind of utilizing LEDs. So LEDs have been around for a while, and the cost of them is kind of starting to get to the point where they're super cheap. So we can actually design this device and use LEDs, keep it affordable, and now the bulbs are not going to burn out for at least 7 years, because LEDs are just super robust in terms of their lifespan. So as I alluded to before, we've developed this device, and it's actually already on the market. And this is a picture of our partner in Chennai, India. They're Phoenix Medical Systems, and so we actually have to license the entire product to them. So they manufacture and distribute the device at their facility here in this picture. And so we still work with them in terms of other aspects around education and trying to identify the key markets that we want to enter into to kind of have the greatest impact. But it's really all Phoenix in terms of making and distributing the device. And so this is just a picture of the first lot that we released. So it's been over a year. So I guess this is from October of 2012. We had the first lot of Brilliance units come off the line and start shipping at Phoenix. And so the device, the cost of the device is about 22,000 rupees, which is about $400 US. So that's a drastic reduction. I didn't do a comparison. I kind of cut the slides out, but other devices can be up to $6,000, $10,000. So this could be essentially deliver the same treatment as any of those devices, because we can design everything to meet the American Academy of Pediatrics standards. So it's pretty much gives us a level playing field in terms of other devices. And so this is just a snapshot showing you we've tracked every device, where it goes, and we really try to, depending on the hospital and the context, we try to keep in touch with each clinic and get the usage information from the device. So this is one of the things I think is pretty cool about Brilliance, is we understood that we would want to measure impact from the beginning. So we were able to put some smarts into the electronics, so it has just a simple circuit board that you turn it on and off. But on the back of it, there's a slot, and we can download how many times it was turned off, how it was used, and different settings like that that can really give us that rich usage information that we wouldn't be able to get otherwise. So we can actually call a clinic, have them hit a couple buttons, and then read off some numbers from the machine, and we'll be able to get the impact data for that device. And so yeah, this is just a map of, so you see mainly we're focused in southern India, and mainly India, but we've reached the Philippines and then a few devices in Africa.
So with your licensing agreement with
Phoenix, do you guys have pricing control?
Yes, we do that because that was a big concern. Is we really want to make sure we're reaching the market, the people, the market that we want to have impact in. And so we capped the price in the agreement. The other thing that we did is we tried to incentivize them to sell to lower income or rural or semi-urban hospitals. So they were an established medical supply company in India, and so they had the hospitals that they were already selling to, which were nicer, urban, bigger hospitals. But we knew that's not really where the need was. So we set up the royalty structure to give them more money if they sold to a lower income hospital. So that was another strategy we kind of used to try to get the impact where we wanted. But it's a tension. It's a tension always. So yeah, just to give you some impact numbers and what we consider impact around brilliance. We estimate that 16,000 babies have been treated so far with the Brilliance device. And then based on some research that we've done in parallel with researchers at Stanford, we come up with estimates for, well, how many babies would not have received effective treatment if Brilliance wasn't there. So, in some cases there might have been another phototherapy device that the child could have gotten access to. So based on our work, we think that's about 13,800 babies. And then we estimate that just over 300 children have been, we've averted them from having brain damage or death due to connectors. So that's it for my prepared presentation, but I'm happy to answer questions for as long as you guys have them.
Is there an associated treatment protocol? And is it hours under the light?
Yes, so it's usually no longer than 48 hours. And the ideal situation is that you're able to do a blood test. So you're able to have a lab that can measure the bilirubin levels every hour or two. That's the ideal situation because, like I said, a few hours can make a huge difference in the levels of bilirubin. But we understand that a lot of places aren't going to have access to a lab. So when we do give out information about how to do kind of the diagnosis, visual diagnosis, which isn't ideal, but that's really the only other way beside a blood test to make a diagnosis. But yeah, no more than, usually it's typically 24 to 48 hours, and you'll start to see the bilirubin levels go.
And is there an optimal wavelength of the light?
Yes.
Okay.
I have the number in my notes, obviously. It's like 490 nanometers or something like that. But yeah, it's a very specific band. There's one of our partners, his name's Dr. Putani at Stanford, and he's kind of a pioneer in phototherapy. And a lot of his research is honed in on that being the most effective wavelength of light.
So how much of the reduction in cost with the Brilliance device is it being manufactured locally rather than in the United States?
I hadn't thought of that one before. So we chose India because it's a good mix of having affordable manufacturing, but still having facility that can do a medical device. So it's ISO certified. They can they have a quality control system. They can do corrective action, stuff like that. But if I were to have to estimate, typically you see, this would just be based on my experience of looking at how manufacturing something in China or India versus US, and it's somewhere between 2 and 5x, depending on the type of device and the things you're doing. But I don't know. I haven't done an analysis. Maybe I don't know what the exact number would be if we manufactured in the US or not.
So I have two questions.
Sure.
The first is, what projects do you guys have at sort of the beginning of the arrow currently?
Yeah.
And just kind of a little bit more about that process. So is it that someone from your team says, oh, I'm interested in addressing some sort of need in neonatal health, or someone says, oh, I've heard of this specific problem, maybe we should look into it more? Yeah.
So we're kind of at an interesting point where we've just launched Brilliance about a year, 2 years ago, a year and a half ago, and we're working on other phototherapy devices, so different form factors. So one of the things we've learned is that a Brilliance unit really isn't great for places that are far outside of a big urban area. So we call it semi-urban or peri-urban hospitals. Brilliance can get into those places, but anything beyond that, we're seeing that we're having a hard time getting a product there. So we've been working on a more transportable, smaller form factor version, using the same concept as Brilliance. So that's kind of the next thing. But that's a big question we actually have open right now, is what will be the next big project? And the big question for us really is, will we focus and stay kind of we've built 2 areas of core competency around neonatal health and mobility aid products. Will we stay within those 2 realms, or will we do something different? And we haven't figured that out yet, and so this will be answering your second part of the question is, I mean, it's a bit of an organic process at the beginning. We get lots of different people coming and talking about ideas, and we see other cool products that people are working on. But then we're also out in the field and maybe identifying things. But we kind of have a process we go through for any idea. We call it we want to do the due diligence to understand, is there really a market for this need, or is there a big market with this need? Can a technology address it? Because we are, at the end of the day, we do make products. So, and a lot of the times technology might not be the best solution for that need. So we kind of have a list of things that we go through like that to really make sure that it's something that we want to work on. So kind of imagine like we get a bunch of ideas and we put them all through that kind of process, and then hopefully in the next 6 months to a year we'll figure out what that next thing is. But yeah, I don't know. I always want to give here's the magic recipe to come up with the next big thing, but it's usually lots of different events that lead you down the path.
Just wondering how stuck on the for-profit model are you? And you just say, like, let's say the Eats Foundation says, this is an awesome joint. Sure. We want to install 100,000 North Africa or something like that. We'll pay for everything. We're going to give it away. Would you guys participate in that?
So maybe to first answer the question, I'll take a step back and talk a bit about what how we see the prosthetics market being. So there's 3 main categories for prosthetic clinics. So there are, clinics that pay for the product and generate income, so like a for-profit clinic. Then there are, in some places, the government can subsidize. And then the third model would be kind of what you described. There are either faith-based or philanthropic clinics that really just donate the product. And we want to try to be agnostic to how the model for each of the prosthetics clinics is at the end of the day. But to answer your question, I think we would only take that money if there was some long-term vision for how the project would be sustained after that phase. So if Gates would say, okay, yeah, we're going to be able to fund knees for all of Africa for a year. Well, what happens at the end of that year? Or, I'm sure they would never say all that. But I think that would be the key in kind of how we would make a decision like that. And that's kind of why we go on the for-profit market-driven model, is because we believe that that's really the only way to keep the project sustained in the long haul. So 10 years from now, would we still be relying on donations to kind of keep the prosthetic knee production up and running? We don't think that would probably be very viable to drive it for that long with donations. But yeah. Did that answer your question?
Yeah, it did. I have a follow-up too. Are you guys doing anything to sort of spread the ethos of your company? Like, meaning, like, let's say you interact a lot with the users to sort of learn their innovations or something like that. Would you actually, support sort of user innovation on their own sort of medical solutions? Does that make sense?
I mean,
sort of an odd statement.
We definitely look. I mean, we definitely look at users
design
for.
class inspired you guys.
Yeah, I mean, we definitely. So I think there's two questions. There might be two ways to answer that question. So there's one about like the design of the product, and that's like, you know, the noise bumper or whatever. Like that's all from users. We didn't think that, or the team at the time didn't think that. But then I think the other question you're kind of asking is about capacity building and kind of teaching people kind of how to do this process. And that's, I think at the end of the day, that's not our core mission. And I think we have to make that distinction. And I think that's important. I think it's important. Because, you know, in my work, I've just personal stories of people I've worked with who really, you know, I think it would be beneficial to have collaborations with universities where we could teach design programs like this, or there's really great work by groups in like Nairobi who are doing technology startups in Nairobi and then building, they call it Gearbox. They're trying to build a maker kind of environment in Nairobi inspired by Tech Shop here to do it there. And I think that stuff's like really important and super cool. But that's just not, I mean, I think we have to be focused on what our mission is. And ours is on delivering the product, not the capacity.
For the Brilliance, which you've licensed out, who's in charge of preparing product and making sure that things continue working for the device there?
That is Phoenix. So they already have because they are an established medical device company, they already had a system in place for sending out technicians when a product failed, or a way to take a product back in and send out a new unit if it was something that couldn't be serviced, or for a unit in Africa they're not going to send. So that, I mean, that's something we're learning, growing pains too, is you know, how can we help support them as they grow to become a global company as well? Right now, they're not going to send a technician to Africa. They're going to have the unit shipped back and then ship a new unit if there's a problem. But as they grow and we kind of grow with them, it's figuring out kind of how to make those better. Because maintenance and servicing is a huge, important part of any product, and it can get overlooked, especially at the beginning. So I'm glad you asked that, and it's something we think about. And you can actually, there's even a warranty plan, I think, that you can purchase with the unit as well that would give you a higher level of service from Phoenix.
I'm surprised that Phoenix hasn't come back to you and brought like maybe a suitcase-sized device, like a little tanning bed.
Yeah.
Maybe like a nurse or some sort of traveling, because it seems, or midwife, you know, because it seems like the technology has also changed in a way that doesn't make it have to be so hospital-centric.
Yeah, that was actually a deliberate decision the team made, was to start by making a device that looked similar to other medical equipment that was out there, because we knew we had to engage kind of the established medical community and convince them to buy into this new product. And we thought that by having something that they were familiar with and comfortable with, but the price was just that much lower, they'd be more likely to adopt. And now in our second phase, we're almost doing something very similar to what you're saying, in making something that's a smaller form factor, that's not going to look, it's not going to have a big stand, it's not going to look like a traditional phototherapy device, but to reach those markets that are harder to access.
My question is kind of about the jaundice itself and what you're saying about how people take the babies home and then they have to bring the babies back.
Yeah.
But is that like, I don't know, like, is it sometimes where the baby is born and the jaundice is apparent immediately and you can treat the baby before they leave, or?
So I'll give you a caveat. I'm not a medical doctor, and I have no special background in jaundice. But what I've learned since working on this project is that it typically doesn't show up until maybe 24 hours after the birth, maybe even up to 2 days, that you see the yellowing of the skin, which actually starts at your feet and works your way up. So by the time it gets to, I think it works its way at the core. It works its way out. So by the time it gets to your fingers and your face, it's super severe. And two, you know, in a lot of the places that we're working, people have darker pigment skin, so it's even harder to identify. because you have to either like blanch the skin like on their nose or their bottom of their foot. You have to look at their gums or pay attention to under the fingernails to really see the symptoms. So it can take a little bit longer before they realize. And then when it gets really severe, the child either can just be crying nonstop or stop crying or stop feeding. If it's really bad, their back will start arching. So it's just when does that diagnosis start to happen, I guess, and it can be longer and longer depending. But yeah, I mean, I think in a lot of places they just don't have, they're not trained to look for it. They don't have the proper equipment to do a blood test to look at their bilirubin levels. So they, there's just there's maybe not even any information passed along to the mother. So it's usually something drastic that causes them to come back.
This blue light, would it hurt babies who don't have jaundice in any way?
That's a good question. The evidence, I would say there's not a definitive answer, but the evidence suggests that there's not. There is some small concern that overexposure, especially in a premature baby that has the skin is more translucent, could have some long-term effect with leukemia. But there's really no sound science behind that. It's just like a concern of the field. So right now, I would say to the best of our knowledge, there is no adverse effect to being overexposed to blue light.
All right, well, thank you everyone for coming, and please sign the sign-in sheet if you haven't already, and help with us. Thank you.